the aim with which we are dealing with these questions in the classes. Okay. So anesthesia for reactive airway disease, we can also call, sometimes it may be regarded as hyperreactive airway. So it is a case of bronchial, so that is bronchial hyperresponsiveness, where the smooth muscles are present. This can develop a airway narrowing or bronchoconstriction, and it will be more intense. You readily respond to lower level of stimulus. That is even a innocuous stimulus. When you go out, you inhale a fume in the house, agarbatti fumes. Many of us don't develop any bronchoconstriction, but a patient with a reactive airway, immediately they may develop a wheezing. Similarly to dust, when you go, people who are not having a reactive airway will be able to walk about without a mask very easily. But if you have a reactive airway, immediately you will develop a wheezing, and you would have seen many people carrying an inhaler in their hand, taking a puff before they come out, and also cover their nose with a mask to avoid a stimulation being hampered. So the first thing that you have to describe in the answer is the airway hyperreactivity. What is the mechanism? Here it is always in the basal state, as you rightly said, there is a mild tonic constriction in all normal human airways. And this is maintained by the vagus more than, and of course it can be abolished by antimuscarinic agents like atropine or glycopyrrolate. And this picture shows the relationship between the dead space and the airway resistance. So here, if you see this picture, the graph, there is a volume of dead space here written here. Airway resistance is blocked on the x-axis, and this is the normal caliber of a bronchial lumen. And when it is dilated, more air will be added here, so dead space becomes increased. On the contrary, when the patient develops the bronchoconstriction, the air passage becomes narrower, the amount of air inside gets reduced, so the dead space gets reduced. That is how the reaction happens, that is the relationship. So this physiological significance is, if you have a normal airway with a normal caliber, then the balance between the anatomical dead space and the airway resistance is enough to cause a good gas exchange and a normal work of breathing. If the bronchodilation happens, it increases the dead space, so gas exchange will be affected, but work of breathing will be very much relieved. On the contrary, if the patient develops a bronchoconstriction, he will have to increase his work of breathing, even though the dead space is decreasing, and still, because he has to do a lot of work to breathe properly, he will be requiring more oxygen, he will be producing more carbon dioxide, and again that will affect the gas exchange. So fundamentally, what will happen if you don't have a normal bronchial caliber is this balance between dead space and resistance will get affected. That will ultimately affect the gas exchange and work of breathing. It is the physiological effect that we get. So the exaggerated response in patients will cause a reducing airway caliber, and this will be aggravated by mucosal edema and airway secretion. So these are the three fundamental effects of a reactive airway. One is narrowing of the caliber, second is the mucosal edema, third is the increase in the volume of secretion. So this airway hyperreactivity is also managed or balanced by the autonomic nervous system. And here there is an increased parasympathetic activity in the lung compared to the other areas. And as I told earlier, the sympathetic innervation, as if the nerves which are sympathetic nerves subserving the lung is very limited. And major influence is via the circulating catecholamine that act primarily on the beta-2 receptors to produce bronchodilation. So that is why we always use the beta-2 agonist by inhalation route. Why we are using it by inhalation route? Yeah, so beta. What is the idea of using these drugs by inhalation route rather than by oral or parenteral route?
Faster
avoid
absorption.
bacteria.
There is
They have
mucosal.
a direct action on the surface receptors. Okay, so you require a smaller concentration, smaller volume, and that will produce an immediate response. That is the reason. So you don't have to use. Whereas if you use a oral or a parenteral, you have to use a larger dose, and this larger dose will, instead of producing only the airway response, it will produce a cardiovascular response also in the form of tachycardia, hypertension, and all those things. So that is the reason why most of the drugs which are used for hyperreactive airway are given by inhalation route. And there are sensory receptors which alter the bronchial smooth muscle tone. So on the bronchial smooth muscle, you have the sensory receptors, and on the parasympathetic vagal pathways are also situated there. And there are receptors called irritant receptors which are found throughout the cartilaginous airway, also prominently in the trachea and especially at the carina level. And this is the one which is responsible for producing the cough. So once, as you all know, the carina is a protective, most sensitive part where the trachea divides, and that receptors are the ones which always produce a violent cough to prevent any foreign material coming into your respiratory passage. So this area, if it is constantly irritated, it will keep on producing a cough, which is very troublesome to the patient. So this mechanical irritation or thermal stimuli or inhaled particles, all these things can act on these irritant receptors, and the result will be a reflex cough, bronchoconstriction at a lower level, and also mucosal. And the different parasympathetic pathways pass down the vagus nerve to the ganglia, and then they go to the intramural ganglia, which are situated, which are nicotinic in nature. So we have both types of acetylcholine receptors, nicotinic as well as muscarinic in the respiratory passage. And this picture will tell you that from the epithelium there is an afferent supply going to the circulatory system, and the efferent pathway is via the vagus. And here in the ganglia you have the nicotinic receptor. Then there are the F1, M2, and M3. The M3 receptors are mainly on the smooth muscle under the mucosal epithelium, and the M2 receptor is the controlling or the negative feedback mechanism, which will reduce the amount of acetylcholine which is going to stimulate this or activate this M3 receptor. So when the M2 is quite normal in its activity, it will not allow a persistent stimulation of the M3 to produce a constant obstruction of the smooth muscle. So this M2 negative feedback mechanism is very important to keep a balance between the production of acetylcholine and the stimulation of M3 receptors. If you understand that point, you will be able to manage that. But when there is a constant trigger, then acetylcholine is being released all the time, and that will go on irritating or producing an action on the M3 receptor, and the negative feedback mechanism is lost because of the persistent acid release. And that is the reason why these people suffer from a prolonged bronchoconstriction. Otherwise, even in a normal healthy person, we may develop a bronchoconstriction which we normally don't feel or experience at all. That is because the M2 is immediately acting and cutting off the acetylcholine which is irritating or which is stimulating the M3 receptor. That does not happen in a patient with a hyperreactive airway. That is one of the main reasons. So the presynaptic M2 is an inhibitory receptor, and they serve to limit the degree of cold melting bronchoconstriction by providing a negative feedback to acetylcholine release from the post ganglionic level. And because viral infection, we mentioned the mechanism. There are neutral endopeptidases which normally degrade the tachykinins. Just because that endopeptidase level is decreased in viral infection, the amount of tachykinin increases, it reduces the bronchoconstriction. And the increased response after stimulation happens if there is a normal smooth entry muscarinic receptor, and which is again the point that I told, loss of immunity function of M2 receptor and the absence of feedback mechanism. This picture again to impress upon you that the M2 is always a minus, negative activity. M1 at the ganglion level gets stimulated, produces acetylcholine, and it goes and acts at the M3 level. M3 is a G2 protein. It's a G protein coupled receptor, so it acts as a G2, which increases the production of protein kinase C and increases calcium. And this calcium is responsible for the smooth muscle contraction. Whereas M2 is a G inhibitory protein. So it causes a suppression of cyclic AMP. And the beta 2 mechanism is mainly de-stimulatory, which causes increase in cyclic AMP. So for any muscle or smooth muscle to get activated and contract, you require a higher level of cyclic AMP as well as a higher level of calcium. If these two things are available, the muscles will contract. And if these two are produced in a higher level, muscle will be going on contracting. That is how the bronchospasm occurs. And that can be inhibited either by decreasing the production of calcium inside the smooth muscle or decreasing the level of cyclic AMP. So that is mainly regulated by M2. So it is the M2 receptor function which is getting affected, which happens in this particular mechanism of bronchoconstriction. Now the preoperative identification, there is no single best test for identifying which patient has got a reactive airway. So you have to ask the patient about what are the complaints they have, because they will not be like a normal patient. They always have this dyspnea and cough problem. So you can ask for nocturnal dyspnea, chest tightness, wheezing. Some people can say, I can hear the wheezing sound, I can hear my breathing sound whenever I try to breathe out. And what factors stimulate all these things, all these questions can be asked, and that is how you presume that they are suffering from a reactive airway. And if you check the FEV1, and if it reflects by decreased FEV1, then it helps to make your clinical diagnosis as a confirmatory evidence. So, if the bronchodilators are able to increase the amount of air that is breathed out, then again it also shows there is a reversibility of the airway obstruction, and then that is taken as an indirect evidence that there is a bronchospasm which is getting relieved with the bronchodilator. So three things by which you diagnose are: one by the patient's complaint, two by the pulmonary function test of measuring the FEV1, three by using a bronchodilator to see whether there is any improvement in the FEV1, which all these things show that there has been a bronchospasm. Otherwise, there is no proper single test with which you can say this patient is having a reactive airway. So, if the patient breathes with a force, then expiratory airway collapse happens because of the forced maneuver. So that also can contribute to the smooth muscle relaxation getting affected, which also add to some extent or mimic like the bronchoconstriction. And the recent upper respiratory tract infection in pediatric patients, these are acute conditions which will make the patient have a reactive airway. So if a patient who has suffered a viral infection suddenly comes with an acute appendicitis, then you have to anticipate that this patient's airway will be quite easily stimulated and going for bronchospasm. And you have to, at the same time, because the nature of the surgery is an emergent one, you cannot deny surgery also. So you have to prepare yourself to manage that situation. That is the answer what they expect from you when you write these questions. And if it is an elective one, you can wait for 3 to 4 weeks. A tonsillectomy, you can wait. Any cleft lip and palate, you can wait. But an acute appendicitis, you can't wait. So that is how you give priority. And the patient, adult patient having a smoking history, then you have to wait for the patient to stop smoking, the take up for any elective. And again, if it is an emergency, a trauma patient, heavy smoker, you have to anticipate that he may have a reactive area and be prepared to manage that. So patients with known asthma or bronchitis patients need to be evaluated well before and treated accordingly. Now, preoperative optimization, bronchospasm should be treated usually with beta-2 inhaled agonist, and complications like the patients are not responding to well with the beta-2 agonist, then sometimes they may need prednisolone, that is steroids may need to be given, or you can give hydrocortisone. And if the patient has got less than 80%, they should be treated with steroids. FEV1 may be taken as a guideline to start steroid if they are not already taking it. And if there are any infections, you have to treat them with appropriate antibiotic. Fluid and electrolyte imbalance should be corrected. And sometimes prophylactic formalin and preventive granulation can be used. Chest physiotherapy and incentive spirometry, all the things for elective cases, which you have to use for the preoperative optimization. And of course, as another patient, you must also ask them to stop smoking. And document any allergic or drug sensitivity, like some of the drugs like aspirin or MSAIDs. Write boldly in the case sheet that not to use that. Nutrition support to make the patient make sure that he has enough muscle power to overcome any difficulty or his workout breathing. Blood gases are rarely used as a guideline, but if it is a patient with a severe asthma, not well controlled, and they have to undergo a major surgery, then of course you can do a blood gas. Coming to anesthetic management, whenever possible, regional anesthesia should be thought of. That should be the first answer that you write in the anesthetic management. So, because that will be the ideal choice, because we are not going anywhere near the airway to mechanically or chemically incite and produce a reaction. But the high levels of sensory and motor blockade produce severe anxiety, and that itself can produce a bronchospasm in the patient. And the second thing is higher levels also block the sympathetic outflow. So the catecholamine release will be less, and whereas low level it is mostly the parasympathetic blockage that is happening, because parasympathetic is craniosacral, as you all know, and the thoracic segment, thoracolumbar outflow is the sympathetic outflow. That will be spared. So older synopsis of Lee usually says, for anything, any surgery below the umbilicus spinal will be ideal for any reactive airway patient or an asthmatic patient, because the unopposed sympathetic activity will facilitate bronchodilation, and patients will feel more comfortable if there is a block below the level of P10. So that is how the mechanism works. And systemic levels of local anesthetic after epidural anesthesia, that also may reduce the hyperreactivity. So if you give a epidural block, give a good volume of it, local anesthetic, actually part of it will get absorbed and come into the circulation, and that also will help to reduce the airway reactivity. Now coming to the general anesthesia, regional anesthesia will not be suitable for all patients. So you have to go for GA. So start with pre-medication, use of glycopyrrolate atropine as a pre-medication, and reduce secretions and will reduce the vaguely indicated hyperreactivity. But as you rightly said, it will make the secretions more thick and viscous. So if the patient is having a lot of secretions chronically, that he will find it difficult to expel it post-operatively. And bronchodilator pre-medication should automatically reduce the airway complications. So you can give a inhalation just before bringing the patient to OT and also pre-operatively adequate intervals. And we can give a dose of hydrocortisone if the patient is already on steroids. Of course, how to supplement hydrocortisone on patients with chronic steroids is another topic, all of you should know. And midazolam will reduce the anxiety-induced bronchospasm. So these are all the things that we have to think in terms of pre-medication. Then coming to general anesthesia management with induction and maintenance, intravenous induction is more smoother than inhalation induction, but pediatric cases, sometimes small babies less than 3 years, we prefer to go for inhalation induction. So the drugs which are preferred for intravenous induction are propofol, as it will give a better suppression of reflexes and also much smoother induction. Etomidate, of course, produce some depression of cortisol secretion, and ketamine, which causes bronchodilation, or the disadvantage is if we increase the salivation and the other secretion. So, adequate premedication with glycopyrrolate or aspirin can prevent that and prevent the laryngospasm that is produced by the secretions. And IV lidocaine as part of the treatment routinely we follow nowadays for every case because propofol also can cause injection pain, so we are using it routinely, and this is more indicated in these type of reactive airway patients. Then, of course, inhalation induction is agent. So in the answers, you can just mention this and then complete the answer. So you don't have to go in detail about each and every inhalation agent, their pros and cons, all these things are not required. You can straight away go for what you are practicing or what is practically possible so that you can save time at the same time you can convey what you have to impress on the examiner. Muscle relaxants which are not histamine produce releasing that you have to take like atractarium or hexametonium, mevalcurium, butypercorin, they are all the ones which can capable of producing histamine, so avoid them. And this use of non-depolarizing muscle relaxant requires the reversible neostigmine. So that neostigmine will increase the level of acetylcholine, bronchospasm happen, but this can be prevented by giving glycopyrrolate separately before neostigmine, not combining as you have the myopyrrolate nowadays. And the use of short-acting relaxants like cisatractarium is safe as it does not cause histamine release, as well as if you wait for sufficient time, the drug will get automatically eliminated by half elimination. And so you can avoid even using neostigmine if you time it properly. And avoid prolonged laryngoscopy, which can trigger spasm. And avoid ET intubation wherever possible. Use LMA, which helps to reduce the chance of spasm. Now, a caution is needed during extubation also, because intraoperative maintenance can be done with volatile anesthetic agent sevoflurane, or other options are PIVA with propofol and remifentanil or ketamine infusion. These are all the methods of intraop maintenance. And during extubation, again you can repeat IV lidocaine or use Bailey's maneuver. What is Bailey's maneuver?
We can extubate that with a tube and we can intubate with the LMA and then extubate.
First introduce LMA and then you extubate the patient. Okay, so that is what is called Bailey's maneuver. So there is no stimulation in the tube is removed in the lighter plane of anesthesia. Then you must write about the intraoperative management of bronchospasm. First thing is switch to 100% oxygen, ventilate by hand, stop stimulation of the airway or the surgery. Consider allergy, anaphylaxis, stop administration of substituted drug, colloid or blood product. Then you can use intraoperative inhalation of salbutamol, which is several methods to instill them into the endotracheal tube if there is an endotracheal tube or through the LMA, whatever strategy you are using. And some of the drugs that are useful are salbutamol, aminophylline, magnesium sulfate, epinephrine, chlorpheniramine maleate, hydrocortisone, and hypertonium bromide, and picanine. So I have highlighted the first letter of all these 8 drugs. So if you combine that, you will get a mnemonic. How do you read that? First letters. SAME,
Same chick.
same. Chick, CHI, chick. Okay, so that is the mnemonic to remember the 8 drugs that can be used intraoperatively. And if surgery is not life-threatening, consider abandoning surgery. Mechanical ventilation with small tidal volumes to avoid high peak airway pressure and trauma. Hypercapnia is, as we rightly said, the word permissive hypercapnia is allowed if oxygenation is adequate, but you must make sure that there is no severe acidosis. And ventilation should incorporate long expiratory time to allow complete exhalation to reduce blood stack. And minimizing peak by slow respiratory rate. Rate should be only about maximum 10 breaths per minute. And an IU ratio can increase from 1 to 2, 1 is 2 to 1 is 3 also is required. And if bronchospasm is severe, sometimes only 3 to 4 breaths per minute may be possible if you allow for full expiration. So this is how you can write this whole answer within about 15 minutes. And read all the points that you want to mention in the exam also.